Welcome to the Registry Insider. I'm Bill Seifarth, CEO and Executive Director for the National Registry of EMTs. And in today's episode, we're talking more about mobile integrated health and community paramedicine, and more of a futuristic, like what are the roles of mobile integrated health going forward as it relates to EMS. Also, we'll talk a little bit about the role EMS clinicians play, and really where does mobile integrated health, community paramedicine, or pre-hospital medicine fit within the realm of the bigger healthcare world. So joining me for today's conversation is Dr. Alex Ulintz. He's he's an emergency medicine physician at the Ohio State University. He's also an EMS researcher. He joined me for a previous episode talking about mobile integrated health and community paramedicine. Also joining us is Dr. Joel Rowe. He is an emergency medicine physician at the University of Florida. He's also medical director in a couple of places. One is in Lake County Fire Department. He's a co-medical director, but also Gilchrist County. He's also a medical director as well at Florida. So, gentlemen, thank you for both joining me, and looking forward to the conversation.
Thanks for having me.
Thanks for having us.
Thanks for the opportunity. Yeah.
Good. So, Alex, last time you and I had a chat, we just talked a little about what is MIH and community paramedicine. And Joel, you do a lot with mobile integrated health. Can you give a little insight as to your story and what piques your interest as it relates to mobile integrated health?
Oh, yeah, sure. Happy to. So I'm an EMS physician, and my perspective on mobile integrated health, community paramedicine really stems out of the fact that as an EMS physician, we've got one foot really squarely planted in clinical medicine, and then one foot like in communities, trying to kind of navigate and work within I kind of offer as the discipline of pre-hospital medicine, of which EMS is a component of. And kind of with that being said, I know that the whole idea around emergency medical response and transport is something that's really, really well recognized in today's society. But the functions that are actually carried out in that, that service being provided encompasses far more than just what's being done and what's recognized. It encompasses preventative health, community health, and public safety. And, that I think that really is one of the things that drives the passion that I have about this, is the fact that that's kind of under recognized in today's kind of healthcare delivery paradigm.
Yeah, and it's also used in a variety of ways across the country, and the education components vary considerably with that. There's not a lot of, uniformity, but there's definitely a need for it. There's definitely a void and a gap that's filling. And I think there's a lot of opportunity as it relates to mobile integrated health, community paramedicine. So, Alex, let's talk a little bit about the visionary aspect of MIH, community paramedicine / pre-hospital medicine, broadly speaking, where, thinking futuristically and perhaps a bit aspirational, where do you envision mobile integrated health going, and what's the potential it has for this healthcare system we're in right now, EMS as it stands today? What's your vision for that?
I think, frankly, the field is wide open for the taking. And I think that's one of the most exciting things about MIH right now, is this adaptability and the ability to, in many ways, influence what the future is going to look like. I think a really good starting point for this conversation is the EMS Agenda 2050. I know there's certainly a spectrum of opinions on that particular agenda, but I think it nicely laid the perspective of what would a person-centered EMS system look like? And what if all of these systems were more about patient navigation, getting the patient the right level of care, whether that's in the home, in the community, in the back of an ambulance, or in the ED, and helping us navigate that piece of what could this look like? So I think EMS Agenda 2050 is a really great starting point for that conversation of person-centric care. What are all the things that EMS is doing in this space? I know the good Dr. Rowe has some excellent thoughts on vision for the future as well.
Thanks, Alex. You're I think might be too kind, but I think it's an interesting question to think about, right, Bill? And Alex, like, I think one of the things we're at right now is, we're trying to figure out as an industry, as a service provider entity, what really mobile integrated health is. I mean, there isn't really a great uniform definition currently. That's what we're trying to figure out. And so having the thought experiment of like, what could it be is, I mean, I was talking to Alex, I was thinking about kind of my 8-year-old boy came to mind, and he was, he wants to be something different every day,
Mm-hmm.
and so it's like, this could, like, where I think this is ultimately is there's a tremendous amount of potential. And I think where there isn't a whole lot of debate is that mobile integrated health really is about service delivery. And it's also about relationship. And I think that what makes EMS, that component of the discipline pre-hospital medicine so special is the relationship that enhances the service delivery that exists. We have a relationship between an EMS clinician and medical oversight that allows for such a force multiplication to occur in our communities, that has done so over the past several decades and really build a community trust. And utilizing that community trust to leverage healthcare services in a new kind of ecosystem of care opportunities, or in really like a pre-activation sense, I think is really a really cool thing to think about.
Yeah, tons of opportunities, that's for sure, as it relates to the vision. And, it's also not something that's novel or new. As we were talking before we started filming, a similar thing has been around since the probably 80s or 90s. It's just evolved and morphed, not necessarily with a standard or uniformity across the country, but it's not new. But it has a lot of potential for future ways of thinking about it. Do you want to elaborate a little bit more on that, Joel, based on our conversation earlier?
Oh, yeah, sure. So, I mean, it was, the phrase that comes to mind is, what is old may be new again. And, in talking with clinicians that have been around for a while, you talk about these different services, different programs that are absolutely impactful in our communities. And having those conversations is kind of funny because people make the comments, oh, we were doing this before, we were doing this back in the day. This was just part of the things that we did. And I think it really, what we begin to realize is that there's kind of two opportunities. One is that these functions that exist within EMS systems, it isn't that they are kind of novel in the sense that like they're not orthodox, but more that they're off-label. And I mean, in emergency medicine, we use off-label, and we have off-label indications all the time. And the off-label functions of EMS clinicians are often very much utilized in an under-recognized way in today's, healthcare delivery system. And the second opportunity that kind of coincides with that is increasing the recognition around those functions in a broader sense of clinical medicine. Because the follow-up conversation I have often with folks that are outside of EMS delivery, public safety, the emergency department, often comes in where they have a confidence that they know what EMS is, but then when they get into it, there's a surprise when they realize there is a distinction, for instance, between an EMT and a paramedic, and that these functions that occur, that it's once they get seen, they then can't be unseen. And I think that's really where we begin to be very well positioned as a specialty, because of that community trust, because of the fact that these are things that have been ongoing, to really leverage a new paradigm in how healthcare is delivered.
So a new paradigm in terms of how healthcare is delivered. So, Alex, from your perspective, where does this pre-hospital medicine, mobile integrated health, community paramedicine concept, where does it fit in healthcare, or is it not clearly defined yet? This is still part of that, I think, visionary question we're exploring.
Yeah, I agree. That's certainly a visionary question. So going back to Joel's earlier point about what's old is new again, I do reflect on a lot of the programs. The earliest ones I know of were coming out of actually like the 60s and 70s in rural Alaska, and then expanded in the early 90s in rural New Mexico. And part of the conversation, I think, is what about the surrounding system either facilitated or acted as a barrier to those programs even working. So I think a lot of the discussion about vision, yes, EMS can take this on their back, and my gosh, our EMS clinicians really good at improvising and adapting to what their community needs. But that doesn't happen in a vacuum, and you need the right community supports, you need the right infrastructure and payment supports to support all of that. So in terms of a vision, I think it in large part depends on what direction our health system takes in terms of, are we willing to acknowledge and reimburse for a lot of these things that EMS does off-label? I think those incentives very much dictate the next steps that we could take. But I could imagine a system in which EMS is kind of the glue that ties together a lot of the dysfunctional, fragmented parts of our health system, this kind of dichotomy between inpatient and outpatient medicine, between clinic-based and community-based care. EMS tends to fill those gaps already, and to see a more formal recognition of that, both in terms of, hey, we recognize that EMS does this, we're willing to reimburse for those services, and we'll build a system that works for it. So system including, can we exchange healthcare information between EMS agencies and hospitals in a bidirectional way where EMS can take better care of patients in the community? I think those would be the first two steps towards that.
Yeah, so you mentioned the word system there. Personally speaking, I love the concept of a systems approach because it talks about the interdependency across all aspects of those who are involved, obviously within EMS, depending on what the type of EMS system it is, but also the healthcare system connected. So there's a lot of potential opportunity there. I guess, where would someone go, Joel, from your perspective, to find out more if they're interested about potentially kicking off a mobile integrated health, community paramedicine, or this concept of pre-hospital medicine? What should someone do? What's like the first step, or where should they go to perhaps start the conversation, to initiate the process?
Well, I think that there are a number of different organizations. At least in my area, there's a tremendous amount of growing interest in trying to figure out how to implement this type of service delivery model. And I mean, I go back to a little bit around, what is a great first step? I think a great first step really comes in creating a common platform for communication between folks that have maybe a more cursory, or it's not that they have an inaccurate understanding of what EMS does, it's just it's incomplete. And an analogy I sometimes use is, we hear, we got to compare apples to apples. And the thing that's predicated by using that phrase, apples to apples, is that both people knows what an apple is before that they can make those comparisons. But if what you feel an apple is really kind of the stem and the leaf of the apple, and what I'm talking about is the entire apple, we're always going to be a little bit off base with each other in terms of talking about what the potential could be. And really, I think that's one of the big first steps we have as EMS clinicians, EMS physicians, having that kind of platform being in clinical medicine, is to be kind of that individual, that leader that makes that or helps bring that recognition to the forefront. Because having the kind of limited understanding of what services are routinely provided by EMS clinicians really then leads to a limited application of what their potential is. And so, this is where we find ourselves now, where we have these conversations and folks are like, well, I didn't even know they could do, an EMS clinician could do this. I thought they flipped a coin to figure out who was going to drive the ambulance that time. Like these are all kind of like, it's this whole big opportunity around recognition. I think would be a very, very good first opportunity to accomplish what you're saying, Bill.
So education, clearly, and I guess overcoming ignorance as to what the capabilities are for EMS clinicians and what the potential is. So I assume an active, engaged clinician who's interested in doing this, working with the medical director and the EMS system and identifying the needs, and then doing some education, are all the processes that would have to go into getting this off the ground if someone wants to do that. But it gets back to that integration within the healthcare system. It's critical.
I think you're right on the money. I think that what we have to begin to do we kind of mentioned systems thinking previously just now. And the thought about that is, there has been in healthcare kind of these, we talk about siloed thinking often. I think that's kind of like a buzz phrase that comes up a lot. But associated with that is there's also labels for resources. Mm-hmm. And those labels help us categorize and recognize how those resources can get leveraged. But if we take more of a systems approach and we instead of looking at the labels, we start looking at the functional impact those resources have within our communities, I think we can begin identifying where overlap and alignment exists between resources that are addressing similar needs, but are being delivered independently. And to Alex's point, that starts to get at the whole coordination of service delivery. And I think one of the things that MIH represents is the potential to help coordinate services, as opposed to becoming like another touch point for the delivery of services, which I feel like in the United States, we have this whole kind of almost like phone booth style where we are setting up all of these touch points. And, that was the whole phone booth kind of analogy was something that one of my EMS captains in Lake County and I had a discussion about, where we have all these different touch points for access, but it's really episodic access. And, one of the questions that we might need to think about and think differently upon is not just how do we increase access, but how do we improve the capacity of longitudinal care to handle unscheduled needs that arise. And that I feel is like a little bit more specific of a question, where I feel MIH is very well positioned to have a good answer, a compelling answer.
One thing that I shared with you previously is in the United States right now, we know in several states, 3, maybe 4, perhaps a little bit more, upwards of 40 to 50% of licensed paramedics, nationally certified paramedics licensed in a state, are not running calls in the back of an ambulance. They're working elsewhere. They could be doing mobile integrated health already. They could be doing some form of that, or community paramedicine, or pre-hospital medicine. But we really don't understand the roles that a lot of these medics currently are playing. We're trying to find that out. The assumption is some of them are working in hospitals and clinics, but also that some of them are doing this type of work that we're talking about today. Alex, your thoughts on that in terms of the role as far as what medics currently are doing, or could and should be doing with the skills that they have, and potentially the additional skills that they can gain through getting some more education?
Yeah. So from the role standpoint, as you pointed out, Bill, there's a wide variation in what medics are doing. I know the registry has been at the forefront of a lot of the workforce surveys to start trying to put names to what is it that EMS clinicians do. In addition to understanding the landscape of what roles are EMS clinicians playing, I think there's 2 key points that sometimes get missed. So one is this kind of false assumption that an EMS clinician can only do one role. When you can do multiple roles simultaneously in the same fire-based service, you could be responding to 911, providing acute care, and also be functioning as a community paramedic all in one call. And teasing out that level of information can be really difficult. The other question here is more along the lines of, where are these roles taking place, and why are EMS clinicians choosing or not choosing those roles? And I think that is a black box right now in our understanding of, okay, well, we know that clinicians take a lot of different roles, whether it's administrative in the back of an ambulance, in a helicopter, in a community paramedicine role, in a private MIH company role. Those exist now. And understanding the motivations of, well, why did you go from 911 fire-based response to a private MIH company, and what are the factors driving those decisions, I think have huge implications for the workforce in general.
Mm-hmm. Yeah, for sure. I mean, there's states where there's a significant shortage of EMS clinicians. That despite the fact our data at the National Registry, our number of clinicians continue to rise exponentially year over year. But they're clearly not all working in the back of the ambulance. We know that. And these other roles and these other opportunities, I think, are great, innumerable, actually. It's akin to what other healthcare, others in healthcare, I'm thinking of nursing. You don't go to nursing school and get your RN and just stick, although some do, stick to one, med surge. They may want to go to the emergency department. They may work in a NICU. Who knows? Obviously, similar in medicine too. So that specialization, that concept of specialization, I think ties in nicely to this role here. This concept of the role that the EMS clinicians can play. So, yeah, I think that's to be determined. But we already know it's happening as we speak, and there's a lot of variability, and I think a greater need for uniformity.
Yeah, I think it also speaks to the continued need to defining the EMS profession to start including these off-label functions that Joel pointed out. Because I think in many ways, first and foremost, it'll always be emergency response, stabilization, and medical transport. But as we take on these other roles, I think that's an awesome opportunity to expand the footprint of the EMS profession. I mean, even to the point where you can have cross-training in multiple things. I know Joel and I had previously talked about the emerging concept of these cross-trained community paramedics who are also community health workers. And there's a number of reasons that may be advantageous, both from a education standpoint and what can be delivered to the patient, but also in terms of understanding the funding paradigm and what community health workers can get paid for. And my gosh, what if we have a cross-trained workforce? Getting back to this concept of force multiplication, I think embracing and understanding and training for these expanded EMS roles is the next step for the profession.
I mean, to kind of add on to that, there was what y'all both were just talking about. There is so much to unpack in what was talking about when we kind of talk about like what the potential is and where things could go. I mean, one scenario very easily could be, we talk about roles, but then, simultaneously, I think one unique aspect that we have to also consider is setting. And, if you utilize, a very easy line of demarcation being a patient calling 911, for instance, activating the system, and then all of the care and resource mobilization that happens after that. If you label all that kind of a post-activation paradigm, and we talk about those things, and we are very familiar with alternative destination. We're very familiar with alternative response and how all those things fit within the activation of EMS. I think where we can now look to with MIH is exploring this pre-activation space. And where it would be beneficial to the EMS systems is talking about how we then prevent some of these calls. We talk about, determinant-based dispatching a lot, where it's, we have a pretty significant amount of call volume that are either non-emergent or, are low acuity or expected to be non-dependent. Basic life services are anticipated. That those kind of calls, which, if you think about it, may be better defined as inconveniently timed urgent care or poorly timed primary care. Right. And EMS clinicians are servicing those calls that are going into the system, and the most expensive way to, resolve those is through the EMS, then ultimately into an emergency department or some form. Well, the adaptability we've already touched on within MIH, these providers connecting with systems of care that are not necessarily episodic, but more longitudinal. Well, we can begin talking about strategies that could actually start mitigating the demand that we're facing in EMS, as opposed to just the more traditional approaches of how do we increase the supply. And even as we're doing that, though, MIH offers I feel like almost a catalyst for workforce development, because what folks I feel like are seeking nowadays is more diversity and opportunity in what they do. And our kind of traditional strategies of incentivizing schedule, incentivizing pay, although they are very important and obviously are very, very much impactful, if we can begin to consider diversity of opportunity, I think we very well may be looking at how to generate or how to create a world of pre-activation or an ecosystem of pre-activation care where it's really the nexus between longitudinal care and episodic care.
It also may help with the retention issues we're having EMS too, because the burnout. For some time ago, the average medic burnout in about 7 years. We're now at 4 to 5 years. So if they have opportunities where I'm done running 911 for a while, I want to try mobile integrated health or community paramedicine. I want to try something else. Or have more of a blended role where not every call, they're back to back running, mostly not urgent, but still back to back calls that aren't able to fulfill perhaps what they're like. So that actually may help with retention if there's more options and opportunities to specialize. So I think there's a benefit to the clinician as well.
I absolutely agree with that. Oh, go ahead, Alex. Sorry.
Thanks, man. I also think there may be an interesting kind of, backfill's not the right word, but maybe downstream impact of expanding MIH. Of does it make frontline 911 response less amenable to burnout? If MIH system is fixing these upstream problems where on the downstream, it's not back-to-back calls and the calls you're going on are truly the critically ill and injured, and you get to help someone and get them to the right level of care, I don't think anyone in EMS dislikes that. It's the everything else that comes along with it. And my gosh, in terms of a vision for a future, what if that vision was when you're doing 911 response, it's to the critically ill and injured? I think MIH can have downstream impacts on those clinicians who may not ever be interested in MIH, but it can make their job more enjoyable.
And it's a win-win situation, not only for the EMS clinician, for the healthcare system, for the EMS system, because as you said, the upstream and downstream effects that it could have created to be a win-win-win situation. Joel, you were going to say something earlier.
Well, I was just reiterating what we're talking about. I mean, going down these paths, I think one thing that is often, I don't think it's often, I think it is, once you see what the potential is, you can't unsee it. Mm-hmm. And you have these conversations, the more conversations that we have with folks outside of our specialty, I think it only bolsters what we are doing in our specialty. And as far as the opportunities go, the idea of offering workforce development opportunities through an EMS system as a focal point, I think is very much an interesting concept or an interesting thought to kind of explore. And that being that the community identifies very strongly with our EMS services. I mean, within the community, I mean, this is something that is even looked at with regards to community trust. And that having that be a focal point for the development and the retention of a workforce within our industry, but then able to connect and coordinate to other aspects of healthcare, we're really starting to get at a coordinated healthcare delivery system that is already embedded within our communities, as opposed to investing more into infrastructure. It's more of how can we reallocate resources? And it's not even talking about replacing anything, because we often talk about other service lines, or we're talking about community health workers and paramedics. Just because a paramedic becomes a community health worker, that doesn't mean that community health workers lose any sort of value or impact within their systems. Both of these skill sets, they're more aligned than they are different. And then how we can synergize between them and how we can enhance current services that are being delivered independently by delivering them in a coordinated fashion. I think that, like what you said, Bill, is a win-win. Everybody wins, and most importantly, patients. Yeah,
which gets back to your first point, Alex. A full circle now. But the EMS Agenda 2050 focused on a person-centric or patient-centric approach. It starts and ends with the patient, and I think they're gonna win. The healthcare system's gonna win. The clinician's gonna win. The EMS system or department's gonna win. So I guess more to come on that. And gentlemen, I thank you both for spending time and chatting with me. And Alex, congratulations, you survived 2 episodes on the Registry Insider. And Joel, it's good to meet you. I appreciate you having some thoughtful conversation with me today about this, because I think it's an important subject that needs to be explored more, definitely at a state and local level, but more equally important at a national level, so we can get some uniformity with it. So thank you both for joining me. Appreciate it.
Thank you.
Thank you. All right. And as always, thank you for watching, and stay safe.
Thank you for joining us for this episode. If you wouldn't mind, please click the like and subscribe buttons, as well as the notifications so you can get notifications about upcoming episodes. Also, for the latest and greatest happenings of the National Registry, feel free to go to nremt.org. Thank you very much. And again, stay safe.